Hello, my name is Laura Ondrisova, and I'm from a research group of Professor Marek Mraz at Sejtek Masaryk University and University Hospital Brno in Czech Republic. Today, I would like to briefly introduce you our manuscript, FOXO1 Rictor axis induces a non-genetic adaptation to ibrutinib via AKT activation on chronic lymphocytic leukemia that is published in the Journal of Clinical Investigation. The treatment of chronic lymphocytic leukemia, or CLL, has marked a revolution by introduction of so-called BCR inhibitors that inhibit B-cell receptor, or shortly BCR signaling pathway. The BCR inhibitors, besides blocking canonical BCR signaling, they also interfere with migration and adhesion of CLL cells, resulting in its mobilization from lymphatic tissue into peripheral blood, causing transient lymphocytosis that usually lasts months until it resolves. We therefore asked whether during this time CLL cells engage some non-genetic adaptation mechanism that help them survive in this relatively stimuli-poor microenvironment of peripheral blood during the first months of BCR inhibitor therapy. And we focused on AKT signaling mainly because in mouse models, when we delete BCR, this leads to dramatic drop of mature B cell count within several days, and activation of PI3K AKT signaling has been shown to overcome this apoptosis in the healthy B cells. We mainly focus on ibrutinib that blocks BTK kinase that is involved in the BCR signaling. And indeed, 70% of cases have an upregulated phosphorylated and therefore activated AKT compared to pre-therapy levels. Furthermore, patients with increased phospho-AKT levels during ibrutinib therapy had a more prominent lymphocytosis which lasted for a longer time than those patients who actually downregulated AKT during the therapy. CLL cells from the patients taken from the patients during the therapy were also more sensitive to AKT inhibition than the pre-therapy samples. Altogether, this shows that AKT is indeed activated and important for the CLL cell survival during ibrutinib therapy. When searching for reasons why AKT is activated during ibrutinib therapy, we performed RNA profiling of paired samples from before and during the treatment, and we observed an induction of mRNA and protein levels of Rictor, which is an assembly protein for mTORC2 protein complex that directly phosphorylates and activates AKT. Furthermore, the levels and activity of FOXO1 transcription factor was induced during ibrutinib therapy. The FOXO1 transcription factor directly binds to Rictor promoter region that colocalizes with the binding of polymerase II, and this binding is actually increased with the ibrutinib therapy. We also observed similar results with other BCR inhibitors such as BTK inhibitor acalabrutinib or PI3K inhibitor idelalisib. This suggested that upon BCR inhibition, FOXO1 increases its activity, leading to induction of Rictor, an assembly of mTORC2 protein complex, activation of AKT, and compensatory CLL cell survival. When we knocked out Rictor, the levels of both Rictor and phospho-AKT decreased. And furthermore, FOXO1 knockout cell line had a major growth disadvantage compared to the wild type in the competitive growth assay when treated with ibrutinib in vitro. This confirms FOXO1's important role in cell fitness during ibrutinib treatment. To study this further, we blocked FOXO1 using FOXO1 inhibitor, which again led to a decrease in Rictor and phospho-AKT levels. Importantly, FOXO1 inhibitor induces 40% of cell apoptosis, and this is increased with combination with ibrutinib or idelalisib, as well as with new generation BTK inhibitors acalabrutinib or pirtobrutinib. We also co-cultured CLL cells on stromal cells that were engineered to produce T cell factors that promote CLL cell survival and proliferation, but even these microenvironmental stimuli could not protect CLL cells from apoptosis caused by FOXO1 inhibition, and furthermore, FOXO1 inhibition also decreased proliferation of CLL cells in this setting. Importantly, FOXO1 inhibition was also cytotoxic to CLL samples that are resistant to BTK inhibitors due to the mutations. In the CDX mouse model, a combination of ibrutinib with FOXO1 inhibitor led to a decrease in infiltration of leukemic cells when compared to ibrutinib treatment alone, suggesting a potential of this combination for elimination of CLL cells also in vivo. In summary, we describe a non-genetic adaptation mechanism to BCR inhibition that involves a compensatory activation of AKT. This activation of AKT promotes cell survival and associates with higher lymphocytosis on ibrutinib therapy. AKT is activated by FOXO1 via Rictor mTORC2 axis, and a FOXO1 inhibitor induces apoptosis and blocks proliferation of CLL cells, suggesting that FOXO1 might be a novel therapeutic target in CLL. Here I would like to thank you for your attention, and if you want to know any more details, please read our manuscript in the Journal of Clinical Investigation.